Good afternoon, everyone. Welcome to the Improvement and Innovation Showcase, hosted by the Commission on Excellence and Innovation in Health, or CEIH. Our Think Sepsis, Improving Care and Saving Lives showcase, and we look forward to hearing from our speakers today. I'd just like to begin by acknowledging that the land we meet on today is the traditional lands of the Kaurna people, and that we respect their spiritual relationship with their country. And we acknowledge the Kaurna people as the custodians of the Greater Adelaide region, and that their cultural and heritage beliefs are still as important to the living Kaurna people today. I also recognise and pay respects to other traditional owners of lands on which you may be meeting that may be outside of Kaurna country. I also wish to just recognise the inequity of health outcomes and life expectancy for Aboriginal people, and sepsis hospitalisations occur around twice the expected rate based on population size, both nationally and here in South Australia. And this requires effort on our part, a willingness to listen and do things differently to improve outcomes. But I also want to acknowledge the resilience and strength of Aboriginal culture, and that sustainable change can be achieved when we engage with Aboriginal leadership and communities. A few housekeeping items. The session has been preset to keep your mics on mute and the video feed is turned off. However, this will be enabled during the question and answer time after the presentation. Only the presentation will be recorded and published. The recording will be stopped for question time. After the presentation, there'll be a really quick survey for you to complete as a poll online, and we'd appreciate you taking a few minutes to do that. And when we have the question and answer time, please use your microphones or your chat function, and you might even like to turn your camera on so we can see you. That would be great. So for those who are unfamiliar with the CEIH, we're the lead agency for innovation in healthcare in South Australia, and we love to bring consumers, clinicians and other collaborators together to turn ideas into better healthcare. And our vision is to get together creating health and prosperity for all. So what if the big idea was connecting all the small ideas? This is the essence of why we host these showcases. It's helping to connect people in South Australia and across our sector, providing a space to explore what others have learnt. It's all about sharing ideas, improvements and innovations. If you have a problem or have some success in solving a problem, whether you've learnt something that you're trying to do so along the way, or you have anything that you'd like to see explored, get in touch with us via the email displayed here on the screen. We'd love to hear also if you have a story to tell, like we're going to hear today. So this is our final episode of the sepsis series of showcases, and our theme is Think Sepsis, Improving Care and Saving Lives. I won't talk a lot about what sepsis is because I imagine you know that, and our presenters today will also cover that off. But in terms of why we are talking about sepsis in this showcase, part of that is because we've chosen it as a priority area across SA Health. Our unwarranted clinical variation has been identified as a system priority by our leadership, our safety and quality teams. And we are progressing a project that looks at sepsis improvement in an area around clinical excellence and safety. That's what we are aiming to achieve across our health system. So the Department for Health and Wellbeing and the CEIH is partnering together to lead that system improvement work. A few statistics here that you can see on the screen about sepsis. We've begun some work to understand the burden of sepsis in South Australia. We're replicating the analysis from the Australian Commission on Safety and Quality in Healthcare, the sepsis epidemiology report that reports approximately 84,000 sepsis cases across Australia. In South Australian public hospitals, there have been about 6,000 separations with an explicit sepsis diagnosis. And although that might be relatively small in number, about in terms of admissions, there's a really high mortality rate, long length of stay, and ICU utilisation for those. And for those who do survive, recovery is often long-term, both physical, cognitive, psychological challenges that result. So I'm really excited today that we are joined by Dr. Jacob Dye and Fiona Gray, who together bring strong research, lived experience, and consumer perspectives on sepsis. Jacob is a senior research fellow whose work focuses on the psychological and behavioural impacts of trauma related to healthcare and critical illness, including sepsis. A survivor of septic shock himself, Jacob combines research expertise with lived experience to advocate for better recognition and support for life after sepsis. Fiona is a sepsis consumer advocate with the Australian Sepsis Network and the Australian Commission on Safety and Quality in Healthcare, and founded the Australia and New Zealand Sepsis Support Group for survivors and bereaved families. So I'm now going to hand over to Jacob, who is going to give the first presentation. Thank you both.
Thank you, Heather, and thank you everyone for coming along and the invitation to speak today. As Heather said, I am a researcher, and I also have a lived experience of septic shock, and was actually in the ICU 3 years ago on this day. And so my background was in psychology, and my research area was how traumatic events impact people's psychological outcomes over the short and long term. And after experiencing septic shock and starting to work more with Sepsis Australia over time, I have eventually transitioned into looking at specifically the effects of sepsis and critical care on people's long-term outcomes. Just across the bottom of the screen there, a series of organizations that we've partnered with across the projects that I'm going to show you today. And so we thank them for all of their help. Today, I will take you on a whirlwind tour, starting with some facts and figures around sepsis, and then talking about my own story of sepsis and my experience surviving sepsis in an Australian healthcare setting, how that impacted me and how we can improve on what we're currently doing, and how partnering with consumers is an important aspect of that. I'll then talk about our work with Sepsis Australia and partnering with consumers and local, state and federal government, including the Commission, and then into some of the research that's happening in the critical care division at the George Institute, particularly with a focus on sepsis survivorship and improving post-sepsis outcomes. And so just a quick definition so that we're all on the same page. The sepsis 3 definition is a life-threatening organ dysfunction caused by a dysregulated host response to infection. And more generally, sepsis arises when the body's response to an infection injures its own tissues and organs. It may lead to shock, multi-organ failure, and death, especially if not recognized early and treated promptly. Sepsis is the final common pathway to death from most infectious diseases worldwide, and this includes viruses such as COVID-19. In relation to COVID-19, there's been recent study released in The Lancet showing updated global estimates of the burden of sepsis worldwide, and that's shown a massive increase in data collected in 2021. There were 166 million sepsis cases worldwide, with 21 million deaths. That increase represented 1/3 of all global deaths, and is thought to be largely due to the impact of COVID-19. More locally, we have updated data from the Commission, as mentioned earlier, showing up to 90,000 cases annually when measured using public hospitals and explicit codes. Of those, 50% were readmitted within the first 30 days and 60% readmitted within the first year. and there was an increase in cost and long-term sequelae. More locally at the George Institute, my colleague Ash Kumar in 2023 looked at cases annually across public and private hospitals and found that there were 135,000 cases in 2021 across Australia. And this again only looked at explicit coding. In further research done by Ash and his colleagues, he's shown that when implicit coding is included, these estimates increase by a factor of about 50%. And so overwhelmingly, the data locally and internationally shows us that incidence of sepsis is increasing, but we also are seeing that sepsis hospitalizations resulting in a live discharge have increased at a similar rate. And so, the positive of this is that although more people are experiencing sepsis, more people are also surviving sepsis. The problem that this presents to us is that we know sepsis has a significant impact on people's long-term health and well-being. And so we now have seen an increase in the need for coordinating and managing people's health outcomes following discharge from sepsis. Overall, despite sepsis being such a common and devastating problem, we see that public awareness for sepsis is quite low. But again, on the positive side, awareness of sepsis has been increasing over time. And so this graph shows data that we've collected across 4 surveys of the Australian public, starting in 2016 and spanning until last year. And you can see that red line in the center has increased consistently over time, showing an increase in public awareness of sepsis that is now getting close to what we see with other common disorders. Despite this, our data also show that only 25% of Australians know what causes sepsis, and then again, only 23% of Australians are aware of the specific signs and symptoms of sepsis. And so although we're getting more name recognition around sepsis, people are not necessarily becoming more aware of what to look for in terms of signs and symptoms of sepsis, or aware of what causes and leads to sepsis. People overwhelmingly in those surveys were also showed a very low awareness of post sepsis syndrome and the kind of ongoing physical, cognitive, and psychological impacts of sepsis. And that's despite the fact that up to 50% of sepsis survivors suffer those physical or psychological effects. And so when we talk about post-sepsis syndrome or the ongoing physical, psychological, and cognitive effects of sepsis, what we're talking about is a grouping of outcomes that are commonly seen in people post-sepsis, and they include impacts on the brain and nervous system, such as PTSD, depression, anxiety, sleep problems, reduced memory, cognitive deficits, etc., all the way through to physical effects on the esophagus, on the pulmonary and cardiovascular systems, the renal system, and then down to things like the metabolism, mitochondrial dysfunction, and then really physical ailments such as frailty, joint and muscle pain, ongoing fatigue, etc. And so what we see with post-sepsis syndrome is a holistic impact on the person's physical, psychological, and cognitive well-being. And we've seen that this can last for years and in some cases even a lifetime. And so these people really need help coming out of the hospital, and they really need coordinated care that recognizes the holistic impact of sepsis on them. And so we'll switch gears for a minute and I think talk about my experience of sepsis. It's a good example of things that can go really well when you survive and are able to walk out of the hospital relatively intact. And then despite that, the ongoing psychological, cognitive, and physical impacts that are often felt in a way that's not obvious and visible to those around you. My sepsis story starts with that gorgeous puppy that you saw on the screen before. Um, Her name was Harry. She was a 12-week-old Harrier pup that we had had for about 2 weeks. And I was playing with her at home, and she put a small scratch on my left shin. That scratch was less than a centimeter, and over the next 24 hours became infected with Group A strep, which progressed to a cellulitis infection. And after 24 hours, my health just started to deteriorate very rapidly. Um, Around 4 or 5 hours after I started noticing uh, these kind of increased symptoms of deterioration, I was taken to the emergency room, admitted, and placed on a sepsis pathway immediately. Uh, that sepsis pathway saved my life by having efficient and targeted care, and eventually ending me in the ICU, where the intensivists and nurses were able to keep me alive. In the ICU, I arrived and was swiftly taken in for surgery. I was intubated while I was awake and put into a induced coma that lasted a little over 5 days. During that time, I went through multiple organ failure. All of the organs in my body were impacted by sepsis, and my family was told that there was very little chance that I would survive. Um, Despite that, I endured multiple surgeries, including a long instance of internal bleeding, uh, and managed to come out of the coma and survive my time in the ICU. Surviving sepsis was extremely difficult and extremely traumatic, but the recovery from sepsis was just as difficult and just as traumatic. Coming out of the coma, I experienced delirium for about a week to a week and a half. Those delirium symptoms were both terrifying and holistically impactful, and have had ongoing impacts on my cognition and my psychological well-being. Um, I then was discharged to the wards, spent 3 to 4 weeks on the wards, and was finally discharged into the outpatient system, where I had a 6 to 12 month physical, cognitive, and psychological recovery. Many of the things that I experienced during that recovery fall under uh, the banner of Post Sepsis Syndrome. And so I don't like to dwell on the negative, and so there were definitely aspects of this that I think went quite well, and I am extremely lucky to be here. I'm very lucky that I went to a hospital that had recently implemented a sepsis pathway. I actually do quite a bit of research with that hospital now, and have met the people that were responsible for that quality improvement project and implementing that pathway. And that sepsis pathway literally saved my life. The modern approach to critical care, again, is responsible for saving my life, but we need to recognize that um, the interventions we're using to save people from sepsis and septic shock also have a long-term impact on their health and well-being. And so many of the sequelae of post-sepsis syndrome can be linked back to the harshness of the interventions that are needed to keep people alive. And so the nerve damage in my hands and feet is a good example of that. I think the dedication of the doctors and nurses in the ICU was beyond reproach, and I am truly thankful to them for saving my life. But I also recognize that there is a good deal of luck in my story, and that I'm extremely lucky not only to be alive, but to have been able to leave the hospital relatively intact. Despite that, aspects of my stay in hospital definitely could have been improved, and my experience post-discharge definitely could have been improved as well. Things like screening for delirium would have improved my stay in the hospital, and certainly meant that the intensive care had a much lower psychological impact than it did. Um, the other thing that was consistently an issue in my stay in the hospital was that at every point of handover between moving from the intensive care unit to the wards, from the wards to hospital at home, and then from hospital at home into the outpatient system, the handover between staff was not particularly thorough. And my GP was left with a very stark and uninformative discharge letter that he had to try to decipher. The education of my family was generally poor, and they were left feeling ashamed and guilty that they weren't able to help when noticing signs and symptoms that would have been indicators of things like delirium and pain. The other thing was discharge information. And this is a common story that we hear from people who've survived sepsis. You leave the hospital with almost no information about sepsis or post sepsis syndrome. Although, despite that, I left with an entire book about post cardiac rehabilitation. And so, although I didn't find out that I'd had a heart attack until about 2 weeks after I woke up, I did leave the hospital with a full book on cardiac rehabilitation. Uh, the final note there is about post-discharge coordination of care, and I think this is a really important one when we're talking about the complexity of sepsis survivors moving out back into the community. Um, Coordinating my care in the outpatient system was a very difficult task, and I am somebody who was well connected in the community, was integrated with the community's health and psychological systems, uh, had been working in hospital for over a decade, and had a good understanding of how that system worked. And I found that extremely difficult to coordinate for myself. I can't imagine how difficult that would be for people who had less privilege than I did leaving the hospital. And so, how do we improve? Well, I credit the use of a sepsis pathway with saving my life, and I'm aware that sepsis pathways are not standardized across states or federally. And so we need to implement consistent use of sepsis pathways. We need to improve transitions of care, moving from the ICU onto the wards and from the wards into hospital at home or the outpatient system. And that should come with discharge information and education. We need to coordinate outpatient care. We need to stop wondering why people stop engaging with the outpatients and end up readmitted to hospital, and recognize that it's an extremely difficult thing to coordinate on your own, and that people with such complex impacts on their health and well-being require help to navigate that system. We also need better recognition of post sepsis syndrome, both in the outpatients, but also in education that comes on discharge, and also in primary health. The final thing that we can do to improve is partner with consumers more effectively. Consumer clinicians and researchers can all learn from each other, and being somebody who spans both the consumer and researcher aspects of that, I can tell you that those perspectives are very different but quite complementary. Uh, Consumer perspectives can foster empathy amongst clinicians and researchers and can change your perspective on how you think about treatments and research questions and interventions. Varied experiences that come from consumers highlight the varied possibilities for improvement, and you shouldn't underestimate the life experience of those consumers. Some of the most amazing people that I've met have been healthcare consumers who are passionate advocates, but also extremely developed in other areas such as law or politics or journalism. The other thing is that engaging with consumers in the community fosters trust amongst your healthcare community. And so it means that the people in the local community trust the healthcare system and are more likely to engage with that system. Partnering with consumers is something that Sepsis Australia is proud to do and has done so for some time. Both myself and Fiona are involved with Sepsis Australia's Consumer Partner and Advocacy Program, and I think are both proud to say that that program has had a significant impact both at the state and federal level. One of the impacts that that program has had is the Stopping Sepsis National Action Plan. This is before my time, but was actually before the Commission's time as well, but was a national action plan put together by what was then called the Australian Sepsis Network, consumers, advocates, and clinicians who came together to build 4 strategic priorities for consensus on sepsis and recommendations for how to implement those priorities. And that National Action Plan was funded in what was called the National Sepsis Program. And that National Sepsis Program's first phase resulted in the Sepsis Clinical Care Standard. There was then extra funding associated with that program, which resulted in the National Sepsis Program Extension. And part of that National Sepsis Program Extension resulted in a business case for coordinated models of care for post-sepsis support in Australia. That project was led and informed by the Commission, the ARTD consultants, and Sepsis Australia. You can find the resources for that on the Commission's website, and it outlines both a case for post-sepsis coordination and care, but also a pretty clear indication that providing that actually results in long-term cost savings. Moving on from the work of Sepsis Australia and the Commission to some research that we're doing at the George Institute that partners with Sepsis Australia and the Commission, as well as Queensland University of Technology, Clinical Excellence Queensland, and Sepsis Australia's Consumer and Community Partner Program. The Post-Sepsis Models of Care program is an NHMRC funded partnership program that seeks to co-design models of support and care for post-sepsis follow-up. This program of work is built on the work of the Commission and the ARTD consultants in designing and developing that first post-sepsis business case and model of care. And it seeks to build a comprehensive model of care based on all of the currently available data, as well as the co-design and investment of consumers, clinicians, and researchers around the nation. And so it goes across 5 work packages across a 5-year period. And so far we have completed work packages 1 and 2 and are midway through work package 3. All of which seek to draw together the available data nationally and internationally, and compile those data into a set of aspects of a model of care that will inform our co-design and eventual pilot testing of that post-sepsis model of care. And so it began with a very broad scoping of the literature, and that took in 26,000 pieces of academic literature from around the world. We screened 16,000 of those pieces of literature and found 131 pieces of literature to include in the review. Tellingly, of that 131 papers, only 6 of those were Australian papers. Even more tellingly, although First Nations people are overrepresented in the burden of sepsis, none of those papers directly referred to First Nations specific issues. We also took in 1,324 pieces of grey literature, which resulted in 28 included in our review, and again, only one of those resources referred to First Nations directly. And so visually, what we're trying to do is take the available data, bring it together into a set of ideas that might be useful for delivering post-sepsis models of care, and then go through a process of co-design with our consumers and other stakeholders in order to develop both an adult and a pediatric model of care. And both of those models of care will be pilot tested in Australian healthcare settings. If you'd like to find out more about that work, you can follow the QR code here, or if you just Google sepsis support, you'll find it on our website. The other work that I wanted to talk to you about today is, again, looking at the impacts of sepsis over the long term, but this is looking at non-critically ill populations. And so the SNAP trial, which is the Staph aureus Network Adaptive Platform trial, is running out of the Doherty Institute at the University of Melbourne, and the George Institute partners with them to look at the long-term impacts of post-sepsis syndrome in non-critically ill populations. This work is the direct result of consumer advocacy. And so Lynn Whiteway, who I think many people here would know, is a passionate consumer advocate and also a member of the SNAP Global Steering Committee. And it's through her advocacy that funding was sought for long-term follow-up for these people who have survived sepsis, although they did not progress to critical illness. And the idea here is to look at and quantify their experience of post-sepsis syndrome following their discharge from the hospital over a 12-month period. This will include looking at structured interviews at 6 and 12 months, and also measuring their psychological, cognitive, and physical impacts over 4 stages during that 12-month period. Finally, this is a QR code to visit the Sepsis Australia website. There are many resources available on that website, and so I implore you to go there and take advantage of them. It is through the hard work of Sepsis Australia and the consumer advocates that have been involved with that program that we've been able to create and deliver these resources for use by local healthcare and anyone else who would find them useful. And that's all for me. I thank you for listening, and I'd love to introduce to you Fiona Gray, who is a sepsis survivor, someone who has been, very supportive of me once I started to get involved in this area. Fiona's experience, I think, predates mine by quite some way, and she has a really interesting perspective on the improvements that have been made over the time that she's been an advocate. Thanks, Fiona.
Thanks, Jacob. Thanks so much to the CEIH for the opportunity to speak today. there's a lot of similarities in my story with Jacob's, but also a lot of differences. One difference is that we're in different states, and I'm really proudly a local South Australian, so it means a lot to me to have the CEIH making sepsis a focus area for 2026. I also want to thank everybody that's joining today, especially to the clinicians that are joining. It means a lot to us survivors and consumer advocates for you to show interest in our story and how that can help advocate for change. We're certainly getting better out there at helping people survive sepsis. But as you've heard a little bit from what Jacob said, we're still not quite as good as we could be at helping people recover from sepsis. So I'll touch on that a bit more in my presentation. In the interest of time, I am going to skim pretty fast over my story. But hopefully as well from the small bit part of my story, it will help you get some key takeaways. So like I said, I'll skim over the story quickly. I really want to focus on that recovery after sepsis and also what we can do better for sepsis survivors. So I think, the real quick version of my story, and I am going to show a slide very shortly, which is a clinical timeline of my experience. I like to follow sharing my version of my story with that slide because I think it's always interesting to hear a patient perspective, but then also be able to overlay that with what the clinical timeline looked like. So my sepsis experience happened about 10 years ago. I was a new mum with a 10-month-old. I was back at full-time work. I was actually still breastfeeding. I was a bit run down at the time with everything I was juggling, but otherwise I was generally healthy, a pretty typical 36-year-old. And I just happened to bang my elbow in the middle of the night on my daughter's cot. Woke up several hours later with it really swollen, really painful, and pretty quickly my teeth started chattering, and I presented to my local ED. I probably will just add there as well, the only other thing, when I said I was a bit run down, I had been suffering from recurring sore throats, and I think that might have a little bit of a connection to my experience because my bacteria that was that I had as part of my infection was strep A. So I think there is a connection there. So I presented at my ED and my local ED, without going into great detail. About 12 hours later, I had been moved to a ward because it had been determined probably about 3/4 of the way through the day that there was definitely an infection there, and they decided to admit me to wash out the infection in my elbow the following day. So I was admitted to a regular ward, but after a short time in the ward, the nurse that did my obs on arrival had to do a MET call, and I ended up in ICU that night. And I was in septic shock. I had emergency surgery and spent the next few days in ICU and then a subsequent couple of weeks in hospital. I think that the couple of key things I want to call out about that experience is I didn't know that I'd had sepsis throughout the time I was in hospital. I'm sure the word maybe got mentioned at some point, but I certainly didn't know what that meant. The word infection was definitely used a lot. In fact, you've had a nasty infection. You're very lucky to have survived was used a lot, but certainly nothing specifically about sepsis for me or my family. And then, similar to Jacob at discharge, I got very little information. Well, I got no information. I was discharged again, just sort of feeling like, wow, I'm very lucky to have survived this nasty infection. And now it's over to me to do take my oral antibiotics and then follow up with outpatients for wound care and take this letter to your GP. So when I subsequently met with my GP in the weeks that followed, she, said the same sort of things that I heard in the hospital. Wow, you've been through a big ordeal, nasty infection. You're lucky to be alive. Just keep taking your antibiotics and you should be fine. The reality, though, was that I wasn't. And probably about 6 weeks later, after really struggling with cognitive issues, anxiety, depression, lethargy, like really finding it hard just to, go about a normal day. I was getting a lot of pressure from work to get back to work. I actually went back to work after 4 weeks post-septic shock because of pressure from work, and I really had to advocate strongly for myself to negotiate just to be part-time to start with, but even that was way too much. And it was at about the 6-week mark that I was just desperate, and I pulled out my discharge letter, and I thought maybe there's something in there to help me understand exactly what this is that I'm experiencing. And I saw the words there, septic shock requiring inotropic support, and I just Googled it. And all of a sudden I found the UK Sepsis Trust in the UK. I found the Sepsis Alliance in America, but I didn't find anything in Australia. And I went back to my GP, and once again, I was just told, you've been through a big ordeal, you'll come good, you'll come good. So no explanation. I was expected to, I work in the mortgage and finance industry. I present to big audiences of professionals in my industry. I was expected to do these presentations. I was terrified all of a sudden after being a really confident speaker because all of a sudden the cognitive issues meant that I was forgetting words. I couldn't put my sentences together. So really lost and alone, which is what sent me on the journey to eventually, luckily, a few months later, I found Professor Simon Finfer and the Australian Sepsis Network, which is now Sepsis Australia, which is very much in its infancy. So the next slide is that timeline that I'll just pause for you to have a quick skim over before I get into some of the key takeaways that I really want you to leave today with. An observation in comparison to Jacob's experience is that there wasn't a sepsis pathway around at the time at the hospital I was treated at. But I definitely think Jacob and I are both very lucky. So I mentioned before that the word sepsis wasn't used, but it absolutely matters for sepsis survivors or families, and even bereaved families impacted by sepsis. We don't want to hear you've had a bad infection, you were very sick. It's really frustrating when the word septicemia or even blood poisoning gets used, because as I'm sure all of you are aware, these are outdated terms that don't accurately cover sepsis. Just sort of looking at it like we fixed the infection now, so therefore finish your course of antibiotics. You should be right now. As you will know, sepsis isn't just an infection. What else matters? As I've said, being told that we've had sepsis and educating not only us but our loved ones, understanding exactly what's happened to us, knowing what symptoms to watch out for, because as some of the data that Jacob touched on, the recurrence of sepsis is really common in survivors. Having that information available during our recovery, education in primary health, a follow-up after discharge, validation that recovery will take time, and support when it comes to work. I'll never forget that at the same time I experienced septic shock, a colleague was probably about 10 years older than me, so he would have been in his late 40s at the time. He experienced a mild heart attack, and the support he got, not only in healthcare as far as rehab, but also like internally in the workplace, he got unlimited time off, because everyone knows what a heart attack is, and our experiences were so different. Also that mental health support, help returning to work and normal life, and having sepsis actually documented. We've made great improvements in data and coding with sepsis, but I still think there's plenty of room for improvement. For me as an advocate, when I'm out there trying to, advocate for sepsis to be get the attention it needs, when I'm talking to decision makers, they sometimes have reference, well, in South Australia, we don't have a problem with sepsis because the data doesn't tell us that it does. So, you know, I can't emphasise that enough. Obviously, we've got lots of wonderful research out there that's talking about the true burden of sepsis. But at the end of the day, I think it's still important to get that coding right. So just to wrap up, because I am really keen to allow some time for questions. I really love how Jacob touched on the importance of working with sepsis. So I just want to again reiterate how grateful I am to the CEIH for making sepsis a priority focus area. This photograph is, I think, 2018, where we came together to work on a national action plan called Welcome to Stopping Sepsis. Stopping Sepsis. And I'm so proud as a consumer that we have contributed I think in such a big way to where we find ourselves today, where we have a clinical care standard for sepsis. There's still work to do. It would be wonderful if we had a uniform approach across the country when it comes to sepsis pathways and then that post-model of care. But like you saw through a lot of the great research and information that Jacob talked about, there is plenty of work going on. But I just will encourage you to really continue to be interested in sepsis. Take on board what us consumers are sharing, and I do think that we're heading in the right direction, and I'm really excited about the change we can make. I think that one of the most important things for me as I got involved in this whole journey with sepsis advocacy is when I realised that sepsis is preventable, and with rapid and the right treatment and with community education, healthcare, we can definitely make a difference. We can save lives, we can save bed days, and we can save a lot of money too. But the importance is investing from that prevention side of things. Thanks so much for having me, and I will hand back.
Thanks, Fiona and Jacob. Wow, your stories were really powerful, and we really appreciate the opportunity to hear that, and it's quite a privilege to be able to share in your story. So thank you very much. Jacob, you certainly have a unique perspective as a researcher and a consumer, which you described. And Fiona, you've got that longer, bigger history of all of this to see how things, how the journey has come and what opportunities there continue to be for improvement.